CMS is quietly cutting Medicare eligibility, and the question every practice and every facility needs to answer is simple. Are you ready for it? There's a 716-page rule that came out this summer, and buried in about page 43,900 is a section with a little bureaucratic title, Limiting Medicare Coverage of Certain Individuals. And most people are scrolling right past it. If you run a physician's practice, a skilled nursing facility, or any other type of provider that bills Medicare, this section is going to land on cycle, and almost nobody's talking about how. I'm going to walk you through what it actually says, who actually is affected, and the 2 or 3 things you should be doing before it takes effect. So let's get into it. I'm Patty Rolls, CEO of Infinium Healthcare. I've spent 30 plus years in the back office of American healthcare, and the billing, the denials, the cash flow side that nobody sees, but everybody depends on. So I read these rules the way an operator reads them. What does this do to a claim, and what does it do to your practice? Here's the background in plain English. In 2025, Congress passed a large reconciliation law. You'll see it cited as Public Law 119-21. CMS refers to it as the Working Families Tax Cut legislation. One section of the law, Section 71201, changed who is allowed to have Medicare. It added new provisions to the Social Security Act that narrows Medicare eligibility to citizens, U.S. nationals, and a defined category the rule calls eligible non-citizens. Essentially, this means lawful permanent residents, certain Cuban and Haitian entrants, and residents under the Compact for Free Association.
The Summer Rule, Physician Fee Schedule for 2027.
Proposed rule is CMS is putting that law into operation. That's not a new policy, it's the machinery, the definition and the termination process, and the paperwork. And I want to be precise here because precision matters on this one. This is a proposed rule. Comments are open through September 14th. Nothing I'm describing is final, but proposed rules are where you will find out what's coming, and this one's coming. Now, here's the first thing I want to correct because I've already seen it misinterpreted. You'll hear people say, this cuts off a huge share of foreign-born Medicare beneficiaries, and that's not right. The vast majority of foreign-born people on Medicare are naturalized citizens, green card holders, and they are not touched by this. Nothing changes for them. The group that is affected is narrowed by a very specific subset. This is a small specific set of current enrollees, refugees, people granted asylum, certain humanitarian parolees, survivors of trafficking and domestic violence, people with temporary protected status, lawfully present, following the rules, and in many cases, elderly or disabled. It's a small group nationally, but this is the part that matters for providers. It's heavily concentrated in dense metropolitan areas, and in certain specialties, it's not going to be small at all. Let me get concrete about what this does inside your practice. The exposure here isn't volume, it's mechanics, and the mechanics are ugly. Start with this. When you run an eligibility check through the usual Medicare verification tools, that check tells you whether someone is entitled. It does not tell you their immigration category, and there's no flag, no heads up that it's ending. The way the rule is structured, the coverage goes from active to terminated with nothing in between. And for most practices, the first signal is that anything changed is going to be a rejected claim. Second, the patient won't know either. Medicare card's still going to be in their wallet. In many cases, Social Security checks are still going to be arriving. And there's a language barrier and the government notice that went unread that's laying on their kitchen table. And that patient is going to walk in your office in February with a card and absolutely no idea that anything has happened. And third, this is the one I'd flag the hardest. The rule sets an eligibility date retroactive to July 4th, 2025. So the open question here is one that's worth asking CMS directly during this comment period, is what happens to a claim that you've already billed and you've already been paid on? If those enrollments get unwound and go all the way back to their start date, What happens to the claims that you've already billed, gotten paid for? Do they become overpayments? Do you have to give it back? And that's not settled. That's exactly the kind of thing that we should be asking during this comment section. Now, where does this concentrate? Nephrology and dialysis, because a lot of this population qualified for Medicare through disabilities like kidney failure, not through age. Oncology and infusion, where you've already bought the drug before you find out the entitlement's gone. And geriatrics and primary care in immigrant communities. Those are the practices that should be paying attention. If you're on the skilled nursing side, this hits you twice, and I do mean literally twice. There's a companion piece in the same law on the Medicaid side. Federal Medicaid matching funds for the same population ends October 1st, 2026, and Medicare terminates for them shortly after. Think about what that means for a nursing home resident who's dually eligible. Medicaid, which has been paying for their custodial bed, can go away first, and then Medicare goes away, and that resident can lose both payers within a few months of each other. And here's the bind. Federal nursing home regulations don't let you just discharge somebody for non-payment. You need proper notice, appeal rights, and safe place for them to go. And for this population, the safe discharge location very often does not exist because they usually can't just turn around and buy a marketplace plan either. So you end up with a person in your bed receiving care, no payer, and no lawful way to move them. And that's generally hard operationally, and it's an ethical problem. The facilities need to be modeling their fourth quarter and their first quarter budgets now, not discovering in an aging report they have a problem. So let me leave you with something you can act on because I don't like problems without giving you something that you can do to try to negate it. One, identify your at-risk residents and patients now, current census and your pre-admission pipeline. I want to be careful how I say this though. You are re-verifying Medicare entitlement. You are not screening people by national origin. You should not build intake questions around immigration status. That creates a civil rights exposure and buys you nothing. The control is how often you re-verify and not by interrogating patients. And two, specialties, the high dollar specialties, the infusion, the drug administration, put a review step in front of the expensive stuff when entitlement has changed since your last check. Don't buy the drug on stale eligibility. And three, watch the calendar and reserve for it. If you know write-offs are likely to be in the first quarter of 2027, put your money against it in advance instead of getting surprised. And fourth, this is a hopeful one. The rule also proposes a path back. If one of these patients gets their green card, adjusts their status, becomes eligible again, there's a special enrollment period so they can re-enroll. For a lot of these folks, the right response isn't discharging them from your panel or your caseload, it's case management. So this case management conversation should be happening. A few months of helping them with a pending application can preserve their coverage entirely, and it's worth doing, and it's the right thing to do, and it's good business. And let me be honest about the limits of what I've told you. Part of this, like exactly how the retroactive piece plays out and whether the terminations land all at once or roll out over time, those are still my read on the structure, not something CMS has spelled out line by line. So if it touches your organization, read Section 3E of the rule yourself and or have someone who lives in this do it for you. Don't wait until the final rule to start thinking about it. The comment period closes September the 14th. The Medicaid side moves first in October 2026, and the clock is already running. If your organization needs help getting ahead of this in the revenue cycle side, modeling the exposure, tightening your verifications, protecting the cash flow, that's exactly the kind of things we do here at Infinium. I'll put a link below. So read the rule, do the math, and take care of your people. I'm Patty Rolls. I'll see you in the next one.